Hello, a warm welcome to all my dear colleagues, trainees, and students, and to the ASCO organizers who are joining us today at this 19th Shaukat Cancer Symposium, which is being held in this virtual format. I also want to extend special thanks to my esteemed panelists and the ASCO organizers who are joining us live from different parts of the world. I am your host and moderator for the session on thoracic oncology. And today we have 3 talks and an interactive uh, group discussion with the panelists, which will hopefully inform us on what is the current state of the art in lung cancer 2020. I'd like to introduce my first speaker, Dr. Kamran Rashid. Dr. Kamran Rashid is a very senior and distinguished oncologist at Shifa International Hospital, Islamabad, Pakistan. He will be giving us a talk on the ASCO Highlights 2020 pertaining to lung cancer abstracts. So without further ado, handing over to Dr. Kamran Rashid.
Thank you very much for the kind introduction. Gives me a great honor, really privileged to be part of the talk. And the topic given to me today was the best of ASCO 2020 lung abstracts. And there were some practice changing, I believe, abstracts presented in this ASCO. And I will overgo some of those abstracts. So with this, my first abstract will be the Adjuvant trial. It was recently published in New England Journal of Medicine a few weeks ago.
Dr. Kamran, if I could interrupt, could you please share your slides, please?
My slides are on.
Okay, are you on screen share?
Yes, they're all showing up on the screen share.
Okay, so could you maybe double click on the presentation again? Because
see hold on a minute. So this is the PowerPoint I have. Hold on a minute. Let's go new share. Should I go new share again?
Yes.
Okay. So
are you? Yeah. Could you double click there?
I'm double clicking. Is it showing up?
No.
No. It's showing up on my side.
Okay. Can you minimize the screen?
My screen? Okay. I can minimize it. Sharing is paused. Bring your shared windows to the front.
Right. Yes, I think that's.
Hold on a minute. Let's see. That's my. Hold on a minute. So can you see my slides now? No.
No.
No. Sharing is paused. Bring your windows to the front. Resume share. Can we share now?
No, we're still not seeing it. So,
hold on a minute. Try one more time.
Maybe could you close down all the windows and then open your presentation again?
Okay, let me just.
Because we are able to see your screen.
You're able to see my screen, but you cannot see my PowerPoint.
Right. It's not being in the forefront, I think.
Okay, you are screen sharing now. Can you see this screen right now?
No. It's still the same screen. Dr. Kamran, so in the interest of time, could we move on to the next speaker? In the meantime, you could figure out the issue with the presentation?
Sure.
I'm sorry. So Dr. Kamran, could you unshare the screen? Thank you. Okay, so I'd like to move to the next presentation. I'm sorry about this technical issue here. We're hoping to fix this and come back to you as soon as possible. So my next speaker is Dr. Taufik Owinokiko. Dr. Owinokiko is a professor of medicine and vice chair for faculty development at the Winship Cancer Institute at Emory University, Atlanta, Georgia. He will be talking to us about the perioperative and adjuvant immunotherapy and TKI adjuvant in the non-small cell lung cancer setting. Dr. Owinokiko, are you able to share your slides?
It's already shared. Can you see it?
Yes, I can see it. You're all set.
Thank you very much. I'm very honored to be part of this great symposium. I'm Taufik Owinokiko. I'm a thoracic medical oncologist here at Winship Cancer Institute of Emory University in Atlanta, Georgia, USA. I really want to thank ASCO and the organizers for the opportunity to be part of this. So here are my disclosures, and these are also available on the ASCO website. This should not have any significant or meaningful impact on the context and content of my talk. And this is the outline that I want to follow today. And I know that our first speaker was also going to talk about the ADORA trial, when everybody's talking about a trial that shows how important it is. And that's going to be part of my talk as well. But since I'm going to be talking about perioperative use and adjuvant use of kinase inhibitors and immunotherapy, this is a very, very rapidly growing field in thoracic oncology. So I'm going to use a few examples just to make the point of how important these strategies are and how they're likely to change our standard of care in the very near future. So some slides on rationale for using adjuvant therapy in lung cancer, specifically non-small cell lung cancer. And then TKI-based strategies as we currently have them, immunotherapy-based strategies, specifically looking at PD-1 and anti-CTLA-4 checkpoint blockade. And finally, I will share some of my own insights into future strategies and some of the key ongoing studies that are likely to read out in the very near future. So why do we need to give adjuvant therapy? I know that this is a diverse audience, potentially of surgeons, medical oncologists, radiation oncologists. So we've all seen this patient. And we know that for lung cancer patients, despite our best effort, majority of our patients do not do well. Even when you look at those patients with very early stage disease, stage 1 or stage 2 lung cancer, where the surgeons will go in and say, we got everything and we expect the patient to do well. When you follow those patients out about 5 years, at 5 years, close to 40% of patients with stage 2 lung cancer will die of the disease. And even for stage 1, we might lose upward of 10 to 20% of patients at 5 years. So there's definitely room for improvement. Beyond surgery, we've always tried to do other things to improve the outcome for patients. One of those is adjuvant chemotherapy. And early studies of adjuvant chemotherapy were non-definitive until we started using effective cytotoxic agents, most of them mostly cisplatin-based doublets. And this is well-known data to this audience of the latest meta-analysis that looked at all the major randomized controlled trial looking at chemotherapy or placebo in early stage lung cancer. As you can see there, that the use of adjuvant chemotherapy conferred about 6 to 7% absolute benefit in terms of cancer-related death. But these therapies are also associated with increased risk of non-cancer-related death, most oftentimes due to treatment-related toxicity. So when you even it out, you see that 5 years, the use of adjuvant chemotherapy improves in absolute term overall survival rate by about 5%. When we look at more contemporary chemotherapy regimen, so on the left is the latest meta-analysis showing that at 5 years, we still lose about 50% of our patients. But more contemporary chemotherapy, looking at the adjuvant therapy trial from ECOG 1505, comparing chemotherapy standard doublet to chemotherapy plus bevacizumab, we see that at 5 years, we're actually now saving about 60% of our patients. So that's about 10% improvement. And this is looking at patients treated with adjuvant chemotherapy alone, but improvement over time. Some of this is better surgical techniques, better supportive care for patients, and potentially maybe introduction of more effective partner chemotherapy such as pemetrexed, along with cisplatin that we now use commonly. If you focus on the more advanced stage patient, stage 3 patient, that is where we start to see that the outcome is really dismal. 5-year overall survival for this patient is only about 20 to 30%. So we lose the vast majority of our patients with stage 3 non-small cell lung cancer, even after they've gone to surgery and they've received chemotherapy or even in some cases, radiation treatment. So this is a real area of unmet need that we need to focus on. And how have we advanced the field? For lung cancer treatment, we typically will start evaluating a strategy in the advanced stage setting. When they look promising, we move them into the early stage setting as adjuvant treatment. That was what we did with chemotherapy. And now in this era of targeted therapy is the same thing we're doing. So now we're beginning to use perioperative TKIs based on evidence that these agents are very effective in the frontline advanced metastatic setting. We're now bringing them into the adjuvant setting. And the most common driver alteration that we currently have in non-small cell lung cancer for which we have effective therapy is EGFR mutation. This is not a new class of patient, but if you look at the evolution of treatment for this group of patients, this is something that's gone on for the past 2 decades, starting with the use of gefitinib and erlotinib in unselected patient population, to when we then recognize that it's the mutation that drives the resistance and the response, to where we now have comparative trial of third-line osimertinib compared to first and second generation dacomitinib, erlotinib, and gefitinib in the FLORA trial. So this is the earliest evidence that perhaps the use of adjuvant EGFR TKI might lead to better outcome for patients. So this is the SELECT trial, was a single-arm trial, looked at erlotinib in patients already treated with chemotherapy to see whether that will improve outcome. It wasn't controlled, but it gave the signal that this could be a reasonable strategy to explore. And unlike the data set I showed you before, where for stage 3 patients, only about a third of patients are alive at 5 years, you can see from this study here that for those patients who received adjuvant erlotinib following resection and chemotherapy, at 5 years, you were saving close to half of those patients. So this was a hint, but this could also be selection bias. So subsequently, a randomized trial with Irradiant was done that randomized those patients following chemotherapy to either erlotinib or placebo. By the time of the design of this trial, we still did not know how important it is to select patients based on EGFR mutation. So this was designed as an all-comer trial. And as would be expected for all-comer trial when you're trying to test a targeted therapy, the primary endpoint of the study was not met. So when you look at the disease-free survival, in those patients treated with placebo, it was 48 months. And in those treated with erlotinib, it was 50 months. So this was read then as a negative trial. But if you look at the subset of patients with EGFR mutation, you see that treating those patients with placebo did not lead to any improvement in outcome, but you see a near doubling of the median disease-free survival to about 46 months, suggesting that selecting patients based on EGFR mutation and treating them with EGFR targeted therapy as a perioperative post-op adjuvant therapy will be beneficial. So the first well-conducted randomized trial in EGFR mutant non-small cell lung cancer was the CTONG 1104 trial. This enrolled patients with N1 or N2 disease and randomized them to either gefitinib or chemotherapy. So this is looking at whether or not you can actually replace adjuvant chemotherapy with EGFR TKI in this population of patients. This is the design of the study. Completely resected N1, N2 positive patients, whether exon 21 or exon 19, good performance status, randomized to receive gefitinib for up to 2 years, or standard chemotherapy platinum doublet of cisplatin vinorelbine for up to 4 cycles. Primary endpoint, disease-free survival. And here is the primary endpoint of the trial, showing that those patients treated with gefitinib actually did better with hazard ratio of 0.6 in terms of disease-free survival than those treated with chemotherapy. So when you take EGFR mutant patient and you treat them with gefitinib, you reduce the risk of disease recurrence or death by 40% compared to treating them with chemotherapy. More recently, at this year's ASCO, we saw the overall survival. So the disease-free survival was the primary endpoint. It was positive. But when you look at overall survival, there was actually no difference between these two groups. While you had early separation of the curves, but once patients stop taking the drug at around 24 months, you see the overall survival curves coming together, and they stay the same for the entire duration of the follow-up, going out to up to 6 years. So this failure to demonstrate overall survival advantage is one of the reasons why this strategy has not taken off, especially in the West. It is now part of the standard approach in China to treat patients with EGFR mutant non-small cell lung cancer with gefitinib as adjuvant therapy instead of chemotherapy. When you look at the updated 3-year and 5-year disease-free survival rate, you see the same story, that once you stop the gefitinib, the disease-free survival impact sort of washes off, suggesting that maybe if you really want to use this strategy the right way, perhaps continuous use of the drug rather than defined period of treatment is the way to go. So if you can keep the patient on for a long period of time, you are more likely to sustain that benefit rather than stopping it at 2 years. Subgroup analysis did not identify any demographic or molecular profile that would suggest the best patient population to use this in. So if a patient is EGFR mutant, every other subcategories that you can look at does not predict for benefit of gefitinib over chemotherapy. But why can we not put patients on gefitinib lifelong? Part of that is the drug is quite, while it is well tolerated, it can have chronic toxicity that makes it difficult for patients to stay on. Even in this CTONG-14 trial, where patients were expected to stay on for 24 months, less than 60% of patients were able to stay on for 24 months because of cumulative toxicity. So there then enters osimertinib, which is a third generation EGFR TKI, which has just now been compared to the first and second generation EGFR TKI and shown to be superior in terms of survival impact. But more importantly also, because it was specifically designed to target the mutant protein and not the wild type EGFR protein, it has a better tolerability profile, suggesting that this type of agent could be the type that you can recommend for a patient to stay on much longer. So there enters the ADAURA phase 3 double-blind trial that looked for patients with resected non-small cell lung cancer. The design here is a little bit different. Patients were allowed to receive adjuvant chemotherapy first as appropriate for the stage of their disease. After that, they then were randomized to either receive osimertinib or placebo. We plan to treat the patient for a total duration of 3 years instead of 2 years in the Chinese trial. Disease-free survival was also the primary endpoint here, targeting a hazard ratio of 0.7. This study was actually prematurely unblinded at the recommendation of the Data Monitoring Committee because of the impact seen in patients on osimertinib compared to those on placebo. What you see here is the primary population of interest, those with stage 2 and 3A disease, with hazard ratio of 0.17. That means more than 80% reduction in the risk of disease recurrence or death in patients who were put on osimertinib versus those who went on placebo. When you look at the entire population enrolled, including those with stage 1B disease, you still see very, very striking impact of osimertinib with hazard ratio of 0.21. And subset analysis show that every demographic subgroup, every molecular subtype, and whether or not patient got adjuvant chemotherapy benefited from the use of osimertinib as adjuvant therapy in this setting. This is the summary slide showing that the higher the stage of the disease, the stronger the impact of adjuvant osimertinib in the perioperative adjuvant setting. So you can see the hazard ratio of 0.12 for 3A disease, 0.17 for stage 2, and 0.5 for stage 1B. While the overall survival data is immature, they only have about 5% of the data available at the time of this presentation, and even with the publication in the New England Journal of Medicine, the overall survival data is not going to be mature for many more years to go. But you can see there that there is no clear separation, at least in terms of statistical testing, for patients treated with osimertinib versus placebo. The two curves are coming together at about 4 years of follow-up, but you did see that initial separation up until 24 months when patient was still on osimertinib. Similar to what we saw with gefitinib, this suggests that perhaps you need to stay on this agent for much longer in order to confer overall survival advantage. Because osimertinib is better tolerated than gefitinib, we expect that a higher proportion of patients will stay on for much longer, and hopefully that will translate into overall survival. So that is just an example, but it's by no means the only targeted therapy that is now being explored in the perioperative setting. LCMC4, Lung Cancer Mutation Consortium, is an amalgamation of academic medical centers in the US, and you can see the map of the US there with all the areas and the institutions participating from the East Coast all the way to the West Coast, where we are now looking at different subsets of non-small cell lung cancer and trying to then evaluate tolerable targeted therapies for each of these cohorts as a way to further improve on the outcome for patients. These will be in form of either single agent targeted therapy or targeted therapy plus chemotherapy as appropriate. I would say stay tuned. You'll be hearing more about these trials as we move forward. So to summarize this first part of my talk, adjuvant treatment with agent targeting the GFR showed reproducible benefits in terms of disease-free survival. We've not been able to show overall survival, but improved toxicity profile for osimertinib might result in overall survival eventually. While this is not yet an approved standard of care strategy, at least in the US and Europe and much of Asia, I believe that the ADAURA data is likely to receive regulatory approval, and that is already under review by the US FDA. Duration of treatment and identification of surrogate marker of disease activity are current areas of interest that we're trying to explore to optimize this strategy for early stage lung cancer patients. Switching gears, since I'm supposed to talk about two aspects of what we do for our patients, immunotherapy and targeted therapy. We all know now that immunotherapy is part and parcel of what we do for our patients. In the advanced stage setting, just like we did for targeted therapies, immunotherapy is now our go-to strategy for majority of our patients, whether it's frontline or post-frontline, either alone or in combination. Keynote-024, this is one of the many randomized trials in this setting, has shown that single-agent pembrolizumab is better than chemotherapy by itself in patients with PD-L1 expressing tumor. And we also know that Keynote-042 replicated the same result in those patients with even lower expression of PD-L1 of 1% or higher. More importantly, regardless of PD-L1 expression, we know that the addition of immunotherapy to chemotherapy outperforms chemotherapy alone. So now we have these two strategies of using immunotherapy for advanced stage non-small cell lung cancer. Immunotherapy by itself or immunotherapy plus chemotherapy. So with the safety of this strategy and the efficacy that we've seen in the advanced stage setting, this is now moving into the perioperative adjuvant and neoadjuvant setting. And I'm going to show you a few examples of very, very tantalizing data and promising results that we've seen with early readouts of this strategy. In the interest of time, I'm not going into the details of all the randomized phase 3 trials of adjuvant immunotherapy because We do not have results yet. And rather than bore you with study design, they're almost all the same. They're looking at immunotherapy versus placebo or immunotherapy versus observation. But what is important to note is we have at least 5 of these trials that are fully enrolled, phase 3 trials. And all we are doing now is waiting for the survivor data to mature to see whether or not they will become part of our adjuvant treatment strategy for patients. You can see them ranging from the Merck trial in Europe, BMS trial, Genentech, AstraZeneca, you name it, everybody has something. And even academic groups such as the EORTC and here in the US, ECOG-ACRIN, we have our own ongoing adjuvant trials that are fully enrolled and waiting for the survivor data to read out. But where we do have data, and just for completeness sake, this is another strategy that is not just looking at IO versus placebo, but looking at whether or not the sequence of IO use in the adjuvant setting will be important. This study will be led by Dr. Jacob Sands from Dana-Farber Cancer Institute, where patients who are adjuvant therapy eligible will be randomized to doublet alone, doublet chemotherapy followed by pembrolizumab, or doublet chemotherapy plus pembrolizumab followed by consolidation pembrolizumab for up to a year. Watch out and stay tuned for this trial in the very near future. But part of the challenge we face with adjuvant trial is how long it takes to get these studies done. By the time the studies read out, is on average about 7 to 9 years. Standard of care would have moved on. So that is where the neoadjuvant approach is very, very attractive. This is a meta-analysis showing that neoadjuvant chemotherapy performs just as well as adjuvant chemotherapy. What is even more important is when you use preoperative or neoadjuvant chemotherapy, a higher proportion of patients are able to complete the planned number of cycles of chemotherapy compared to if you give it as adjuvant. So suggesting that if we believe that this will work in the adjuvant setting, perhaps it should also work in the neoadjuvant setting. The challenge we face with the neoadjuvant setting, though, is that we do not have, if we are not going to rely on survival, what are we going to rely on? We don't have a biomarker that we can just use, but over time, and in the breast space, we know that pathologic complete response could be a surrogate marker for overall survival and disease-free survival. Historically, with neoadjuvant chemotherapy, we do not see complete pathologic response in lung cancer, but we do see what we call major pathologic response, meaning less than 10% viable tumor cells in the resected specimen. And the more the amount of viable tumor you see in the resected specimen, the worse the outcome for patient. So when it is 1 to 10% as your baseline, for every 20% increment in the viable proportion of tumor cells, you almost doubled your hazard ratio for death. When you look at those patients where you had major pathologic response, where you had less than 10% of viable tumor left, that is actually the best population of patients. And this has been shown to correlate with overall survival. As you can see there, if you have less than 1%, less than 10%, going out to 120 months or 10 years, close to 80% of those patients will still be alive. So with major pathologic response now as a surrogate endpoint, there are now ongoing and some completed trials. The earliest of this effort was neoadjuvant nivolumab that was conducted by investigators at Johns Hopkins University and Memorial Sloan Kettering Cancer Center here in the US. They took patients with resectable non-small cell lung cancer and used a window of opportunity strategy to give them 2 doses of nivolumab, just 2 doses of nivolumab. And then patients were taken to surgery, at the end of which the resected specimen was analyzed for major pathologic response. The primary endpoint of this was actually to show that this is safe, that you can give neoadjuvant immunotherapy and still take patients to surgery. And this is the result that they showed. From this relatively small study of about 20 patients, you can see that just 2 doses of neoadjuvant nivolumab conferred some degree of regression in tumors, but most importantly, is the degree of major pathologic response and the risk of recurrence. Up here in blue lines, and this is months of follow-up. All these patients in blue, those are patients who achieve major pathologic response. And you can see that only one of these 9 patients suffered disease recurrence over time. If you look at those with no major pathologic response, more than half of them had disease recurrence when you follow them over time for 3 years of follow-up on this trial. A picture is worth 1,000 words. This is one of the patients on the study, CMC3, which is atezolizumab. Same story. You can see patients with major pathologic response in about 19% of those patients, also showing that this is feasible, you can do it, and it is safe. And also there was pathologic response and risk of recurrence of patients. Finally, the NEOSTAR, or neoadjuvant nivolumab versus nivolumab plus ipilimumab. This was looking at combination strategy of anti-PD-1 and anti-CTLA-4 to see which of these 2 strategies would be better. 2 cycles of immunotherapy were given, patient went to surgery, and then resected tumor samples were examined for major pathologic response as the primary endpoint. Shown here is the rate of major pathologic and complete pathologic response of 17% in those patients treated with nivolumab alone and 33% when you combine nivolumab and ipilimumab. Unfortunately, the combination was a lot more toxic than the single agent, and PD-L1 expression did not seem to be a viable biomarker to know who is going to benefit from such a strategy. This is a summary of the 3 neoadjuvant immunotherapy alone, showing that major pathologic response rate of about 24% compared to major pathologic response recorded from neoadjuvant chemotherapy of 20%. Finally, at the World Lung Conference last year was this very, very interesting study from Spain, where they took this one step further of neoadjuvant chemoimmunotherapy, looking at those patients with stage 3A disease, either N2 disease or bulky primary tumor. Patient got 3 cycles of chemoimmunotherapy, went to surgery, and then followed that up with 1 year of immunotherapy. And interestingly, when you look at the result here, the major pathologic response here with this chemoimmunotherapy strategy was 83%. Now, I just mentioned 24% for immunotherapy alone. Here it is 83%. And complete response was 60%. More importantly, we all know that for stage 3 patients, if you do chemoradiation, you give them maintenance or consolidation durvalumab, progression-free survival, as well as overall survival is improved compared to chemoradiation alone. And the PFS rate from the Pacific trial at 18 months was 52%. In this trial, the PFS rate at 18 months was 81%, suggesting that this could be a really, really viable strategy to further improve the outcome. So these are some of the selected phase 3 trials of neoadjuvant immunotherapy along with chemotherapy. Most of them may be halfway enrolled or almost enrolled, and primary endpoint for them ranges from major pathologic response to event-free survival and pathologic and overall survival. So in summary, immune checkpoint blockade as adjuvant therapy continues to be investigated, either following chemotherapy, concurrent with chemotherapy, or as an alternative to chemotherapy altogether. Several studies already completed enrollment, and we're now awaiting data maturity to see what the overall survival impact will be. I want to also submit that the neoadjuvant approach has shown us very, very intriguing results, especially when you look at the combination of immunotherapy agent or chemoimmunotherapy. And I'm very, very convinced that major pathologic response will be a validated surrogate marker that we can use to fast track this strategy for our patients. And all the ongoing phase 3 trials that are currently enrolling believe hold great promise and that they're likely to alter the standard of care for our patients in the very near future. Again, I want to thank the organizers and ASCO, and I thank you all for listening.
Thank you very much, Tawfiq. This was an excellent overview. Really appreciate your talk. So I will go back to our first speaker, Dr. Kamran Rashid, see if he can share his slides now. Dr. Kamran, are you there? Please unmute your mic, please.
So sorry to the audience for the misunderstanding. And I believe whatever happens, it happens by God will. So it's a very nice review. And so with this, my 4 lung abstracts will be dealing disease in the metastatic setting. Without wasting further time, I will move on. So the first study, which our esteemed speaker just talked about, the ADAURA study, recently published. Ramalangan was the primary author on this study in New England Journal of Medicine. And this was the adjuvant use of osimertinib, which after FLAURA has become the standard of care in the metastatic setting. And they looked at, this is the study design, that the patients were stage 1B onwards to 3A. And this was with and without chemotherapy. So if you get chemotherapy, there's a 10 weeks, 26 weeks with adjuvant chemotherapy. And if you get without chemotherapy, there's a 10-week wait till they get the osimertinib. And it was based on the EGFR mutation status, 19del L858R. And the patients were randomized to osimertinib versus placebo. The primary endpoint was disease-free survival. And the secondary endpoint was the overall survival, disease-free survival in the overall population. So this study, actually, these are the patient populations. And you can see the study was pretty much well-balanced, osimertinib versus the placebo group, the EGFR mutation, the histology, adjuvant chemotherapy. 50% of the patients got chemotherapy and 50% did not. This is basically the disease-free survival, very impressive. You can see that the disease-free survival for osimertinib has not been reached, and for placebo, it's 20.4 months. And the next slide shows for patient population 1B, 2, 3A, and these are the subgroup analysis, the forest plot. It just shows that all the groups, they benefited from this treatment. And as the disease stage progresses, you can see that the benefit, it goes up. So the hazard ratio for stage 1B is 0.5, and it goes down to 0.12 as the stage progresses. And this is the breakdown of the disease-free survival by the stages. And you can logically, as the stage of the disease progresses, the DFS goes up. And this is actually the overall survival. As our speaker just talked about that, it needs a longer follow-up. But now for osimertinib as well as for placebo, the overall survival has not been reached. And maybe with longer follow-up, we'll be able to get better answers. And this is the safety summary. It's pretty well tolerated. And the overall adverse effects are not significant. The commonest adverse event in osimertinib population was diarrhea, which was 46%, and some other skin changes, cough, stomatitis, nasopharyngitis. Nothing significant. So the conclusions are that there is a 79% reduction in risk of disease recurrence or death with osimertinib. And osimertinib disease-free survival at 2 years were 89% versus 53% respectively. And adjuvant osimertinib will provide a highly effective practice-changing treatment for patients with stage 1B till 3A EGFR mutated non-small cell lung cancers. Now we'll switch gears to immunotherapy. This is the CheckMate 9LA trial. Let me just talk about briefly the background, that the CheckMate 227 has very clearly shown that Nivo and IPI versus chemotherapy is shown to improve survival in non-small cell lung cancer, irrespective of histology and PD-Well expression. And similarly, another trial, CheckMate 568, had part 2, in which chemotherapy was combined with IPI and Nivo. So this strategy has been shown to be a possibility. So this led to this CheckMate 9LA trial. It's a phase 3 randomized open label study in which, let me show you the study design. It's a stage 4 non-small cell lung cancer. Basically, no prior chemotherapy was given. No sensitizing EGFR mutation or ALK alterations. They had good performance status, and they were stratified by PDL1 less than 1 and more than 1%, and on the histology, squamous versus non-squamous. And they were randomized to 2 cycles of chemotherapy with Nivo and Ipi. Whereas the other arm got chemotherapy 4 cycles, and there were optional pemetrexed maintenance. And the treatment was continued in the immunotherapy arm until disease progression, unacceptable toxicity, or for 2 years of immunotherapy. The primary endpoint was overall survival, where our secondary endpoint was PFS, overall response rate, and efficacy by tumor PDL expression. This is actually the baseline characteristics. You can see that patients are very well matched. Different types of PDL1 expressions from less than 1% to more than 50%. Histologies, squamous versus non-squamous, smoker versus non-smoker. So a very well matched group. And this is actually the exposure. And you can see that the patients, the number of doses of Nivo and Ipi given, 9 and 4. And similarly, treatment discontinuation. Logically, Nivo and Ipi is a toxic combination. Giving it with chemo can be a challenge. And there were like 74% of the patient who discontinued, and number of cycles of chemotherapy received. Maintenance was more in the chemotherapy. These are the curves. This is the overall analysis at interim analysis of 8.1 months. And you can see that the Ipi-Nivo arm had an overall survival of 14.1 months versus 10 months in the chemotherapy arm. And when we look at the updated overall analysis, that is 12.7 months. The Nivo Ipi arm was still winning with a 15.6% overall survival compared to 10.9%, which was the primary endpoint of the study. And this is basically the overall survival subgroup analysis. And you can see that mostly all of the groups, they benefited from Nivo and Ipi plus chemotherapy, where only 2 cycles of chemotherapy were given. You know, the only 2 subgroups which I see were on the left of the one side are the elderly patients with an age more than 75 and patients who were never smoker. And this is by breaking them down into the histology, non-squamous versus the squamous. And you can see that the non-squamous, they had a slightly better median overall survival compared to the squamous patients. Similarly, based on the PDL1 expression, less than 1%, more than 1%, 1 to 49%, and more than 50%, all the subgroups, they benefited from this strategy, combining Nivo Ipi with 2 cycles of chemotherapy. And this is by blinded independent central review. The progression-free survival, it still holds on. And what they showed was that another interesting thing in this trial was the duration of response. And you can see that the duration of response was 11.3 months in the arm getting immuno plus chemotherapy. And you can see that at 6 months and 12 months. And at 12 months, it was almost doubled in the arm which was getting the chemotherapy with immunotherapy. These are the side effects profile. As expected, adding Nivo Epi to chemotherapy, it bumps up the adverse events, and serious adverse events were 25.4%, which was grade 3 and 4, you know, more than the chemotherapy arm. So obviously, this is something we have to keep in mind, that this combination can be slightly more toxic than the chemotherapy. These are the typical, there's on the left-hand side is the Nivo Epi plus chemo, and on the right-hand side is the chemotherapy arm. Anemia, neutropenia, alopecia, febrile neutropenia was pretty much comparable, neuropathy was comparable. So pretty much comparable side effect profile. And these are the treatment-related adverse events in immuno plus chemo. And you can see more of skin changes, endocrine, gastrointestinal side effects, which were not seen in the chemotherapy-only arm. So basically, it has met its primary endpoints, and the meaningful improvement of all endpoints was observed. And with a minimum follow-up of 12 months, overall benefit was further improved, which is a hazard ratio of 0.66. It was irrespective of the PD-L1 status and irrespective of the histology. There were no new safety signals, and that led by the authors to suggest that this will be another option in the armamentarium of managing non-small cell lung cancer with a limited course of chemotherapy, and it should become another standard of care in these patients. Then NAJ 026 study, This is actually a study in which stage 4, 3B and 4 non-small cell lung cancer patients with activating EGFR mutation, exon 19 deletion and exon 21 mutation, asymptomatic CNS metastases were given either erlotinib monotherapy or bevacizumab with erlotinib combination. And on progression of disease, they were allowed to get chemotherapy. The arm with bevacizumab and erlotinib was just given plain chemotherapy without bevacizumab, pemetrexed and platinum. And whereas the arm which just got erlotinib up front, that arm got bev with chemotherapy with maintenance. And this was the primary endpoint of the study was progression-free survival, whereas the secondary endpoint was overall survival and exploratory endpoints for PFS2. So this study presented the overall survival of the study. So this was PFS has been presented, and you can see in this slide that the PFS was better in the arm which got bevacizumab with erlotinib upfront, 16.9 months versus 13.3 months. And this is actually the patient disposition, how the second line treatments went on. You can see that half and half of the patients got osimertinib. The bevacizumab arm got osimertinib on disease progression as a second line treatment. And similarly, chemotherapy was also given in the arms once they progressed on the TKI. And this is the overall survival, and which was pretty much not significant. The overall survival was 50 months for the bevacizumab and erlotinib arm versus 46 months for the erlotinib arm. And this is the hazard ratios and the subgroups showing what benefit was there. And pretty much, the numbers are lined up on, in the middle. There was not much of a difference in favoring one treatment versus the other treatment. And this is based on the deletion, that exon 19 deletion somehow did not benefit from adding bevacizumab with erlotinib because their overall survival has not been reached in the erlotinib arm. Whereas in the exon 21 deletion, the arm which got bev with erlotinib had the overall survival advantage, that is 50.7 months versus 38.18 months. And similarly, both the arms benefited if, as a second line, if they got osimertinib. So arm which had bevacizumab and the arm without bevacizumab, you can see the overall survival was 50.7 months, whereas in the erlotinib arm, this overall survival has not been reached. Another thing to look for in the future for these groups. And this is the PFS2 that after they progressed on the front line TKI, then they got chemotherapy, as a second line. And what is the PFS2 after getting chemotherapy? And this was pretty much comparable between the bevacizumab erlotinib arm versus the erlotinib. There was not much of a difference in both the arms. So the PFS2 was not significantly different between the BE and erlotinib arm, and the bevacizumab erlotinib treatment had less benefit on PFS2 compared to PFS1. And addition of bevacizumab to erlotinib monotherapy provided no further benefit to overall survival, and characteristics related to a more favorable overall survival were not found. So this is the take-home message that bev and erlotinib combination causes a longer PFS, but it has no impact on PFS2 overall survival. And this advantage gained earlier on was lost with a longer follow-up. And this was in comparison to the JO25567 study, which was previously presented by another Japanese investigator, and which showed that there was no impact on overall survival if you had bevacizumab up front. And what was the reason of this BE treatment to improves overall survival? Can be these second line treatments. Once these patients progress and they get second line osimertinib, and they get other treatments, that second line chemotherapy may take away the benefit of the PFS and has an impact on the overall survival. So it's very, very important in these patients that if they get erlotinib up front, the second line treatments should be offered to these patients, because these treatments has an impact on improving the survival of these patients. And bevacizumab induced 790M resistance, just like first generation TKI. So these are the messages which were learned from this trial. And finally, the fourth study I would like to present is, which I believe is very impressive, that these patients who are failing 3-4 lines of treatment, they don't have much options left. And this is the Destiny Lung 01 investigator study, in which trastuzumab deruxtecan was used in a group of patients. And let me show the study design. So these are the patients with unresectable metastatic non-squamous non-small cell lung cancer. They were relapsed and refractory, and majority of these patients have received 2 lines of treatment, and they can be either HER2 new overexpressing by IHC, or they can have activating mutations. So there were 2 cohorts in these patients. One cohort was HER2 new overexpressing IHC3 or 2 by IHC, and the other arm had HER2 new mutated disease, which was done, mutation analysis were done. And the primary endpoint was overall survival by an independent central review. And these are the patient baseline characteristics: male, female, HER2 new mutation, kinase domain mutations were the commonest mutation seen, whereas there are some extracellular domain mutations were also seen, and there were some not reported. The presence of CNS metastases were 45, because this treatment was used later on, so more patients, 50% of the patients had CNS metastases at the time of this trial. And these are the number of therapies. So all of these patients got the platinum-based chemotherapy, second-line immunotherapy, and then as a third line, maybe docetaxel. So the range of therapies were from 1 to 6, and median range was somewhere in the range of 2. So they are pretty heavily pretreated patients with not much options left. And this is what the overall response rate was 61%. It's very, very, I would say, very encouraging. And the majority of patients have PRs, that is 60%. Some patients had stable disease of 28.6%. The PFS was 14 months. So this is the waterfall plot. You can see that anything below 0 means that the tumor was regressing. The best change in size in the tumor, and you can see the size went down as low as 80%.
Dr. Kamran, sorry to interrupt. You have 5 more minutes. Thank you.
And progression-free overall survival was 14 months versus the overall survival has not been reached in these patients. And these are the treatment-related adverse events: the nausea, alopecia, blood counts. Majority were grade 1 and 2. Very few were grade 3. And the overall safety summary. So the most common adverse effects with dose reduction were fatigue and nausea. And the common interruption with the introduction of treatment were decreased neutrophil count and lung infection. Another important thing which has to be careful about is interstitial lung disease. 5 patients developed grade 2 interstitial lung disease. They were all treated with steroids, and majority of their interstitial lung disease went away. So these are the conclusions: that overall response at 61%, duration of response not reached, PFS was 14 months. So it's very, very impressive. So these are my conclusions from this ASCO. DORA showed a new adjuvant treatment option, osimertinib. Checkmate 9LA gives a new standard of care, ipi-nivo, with 2 cycles of chemotherapy. Destiny Lung 01 gives us trastuzumab deruxtecan as a new option as a second or third line in HER2 new positive lung cancer. And NAGA 026 showed no overall survival advantage of adding bevacizumab to erlotinib in upfront setting. With this, thank you very much.
Thank you, Dr. Kamran. Please stick around for the case discussion and questions in the end. I will move on to my next distinguished speaker, Dr. Abdul Rahman Jazia. He is chairman of the Department of Oncology and professor at the King Saud bin Abdulaziz University in Riyadh, Saudi Arabia. Dr. Jazia will give us a talk on small cell lung cancer and some updates. Dr. Jazia.
Good morning, everybody. It's a pleasure to be here with you. Do you see my slides?
Yes, we can.
Great. So I'd like to thank the organizing committee and for inviting me to this prestigious conference. I will be talking about extensive small cell lung cancer. As we know, small cell lung cancer constitute 13 to 15% of all lung cancer. While this is a small fraction, when you think about the 2 million people with lung cancer, all of a sudden you realize that there is more than 250,000 people affected with this disease worldwide. While we know a lot about the molecular profile of small cell lung cancer, none of this knowledge actually is practically applicable to help our cancer patients, unfortunately, unlike what we have seen in non-small cell lung cancer. We also know a lot of things about the biological behavior of the disease, which are the knowledge we know is very important for the clinical practice. And small cell lung cancer is rapidly growing tumor that has predilection to neuroendocrine systems. So it's likely to present with metastatic disease more than non-small cell lung cancer. And the overwhelming majority of patients are smokers, like 98% of patients with small cell are smokers. And there's no targeted therapy yet for small cell lung cancer. It's very important for the clinician here of all disciplines to realize that the importance of this tumor behavior of small cell lung cancer. So if you have somebody diagnosed with a small cell lung cancer and you order CT scan in 2 weeks and MRI of the brain in 3 weeks and follow up in a month with the clinic, patient with extensive stage lung cancer already lost half his life. Because extensive stage small cell lung cancer untreated, they live 2 months to 3 months, 8 to 12 weeks. So if you diagnose the small cell lung cancer, please hold into the patients, especially in our countries that patients may be living remotely, follow-up may not be reliable, and so on. You have extensive stage small cell lung cancer, please handle it in as urgent as you can. Because the treatment does make a difference. While we are not curing many extensive small cell lung cancer, we can quadruple the overall survival easily. It move from 2-3 months to 10 months and so on. And some small group will live much longer than that. And in limited stage, we can cure subset of the patients, and also we quadruple the overall survival of patients from 6 months to 20+ months with the limited stage. So that's very important clinically to keep in mind. Now, for practical reason, and I like many of our lung cancer doctors like the classification of staging of lung cancer that's done by the VA lung group, which is basically dividing it into 2 categories. And that's for practical, pragmatic, therapeutic purposes, which is therapeutic. So, limited stage in simple way that, any disease that you can encompass with single external beam radiation. So even if there is N3, even if there is contralateral lymph node, supraclavicular lymph node, or mediastinal lymph node, in the other side of the lung of the primary, you still can consider a limited stage, and that's very important because the treatment is totally different. The approach is totally different. The outcome is totally different between these 2 categories. So that's why I'm going to use an NCCN guideline as framework of our discussion. Because it's updated very frequently, and it's the most commonly used guideline worldwide. And I will use the latest version here. So when you get a tissue diagnosis of small cell lung cancer or combined histology, small cell and non-small cell, you need to do the usual workup of cancer patients. I'm not going to go into details in this, but the bottom line is you need to make sure that you have good brain imaging, and basically you have to determine whether the patient has limited stage and extensive stage. You need CT scan of the abdomen to make sure that you cover the adrenals well as the whole liver. And if you have access to PET scan, that will be good to do. Usually we don't do molecular profiling unless in rare cases somebody who is non-smoker that has small cell lung cancer, and you may have some doubt that they may have other combined histology or something like this. So focusing now on extensive stage small cell lung cancer. Once you have established the diagnosis and the stage, and then you have to decide about the treatment, and the prioritization of the treatment will be based on the symptoms of the patient. So if the patient has local symptoms of mass effect related to, for example, superior vena cava or lung obstruction, bone mets, spinal cord compression, or brain mets, you have to focus on treating these local treatment. Although many times for superior vena cava, I mean, patients' tumor melt away with the chemotherapy. So sometimes you can get away with starting the chemotherapy and not give just palliative radiation, especially in limited stage, by the way. If you give palliative radiation therapy to SVC, then you will not know what to do with a definitive chemoradiotherapy. Nevertheless, for brain mets, and I have an issue with this in all across NCCN guideline, and any guidelines actually, that divide patients into asymptomatic and symptomatic. What do you mean by asymptomatic? Wait till they have symptoms. And then once they have symptoms, most of the time you lose control of the situation. Patient will have poor performance status. Symptoms in CNS mets could be mean stroke. The patient is paralyzed, done for it. So for me, and especially in our countries where, again, the follow-up of the patients and where the patients live is an issue, I would manage CNS mets early on. I would not observe in small cell lung cancer brain mets. We can talk about other brain mets in non-small cell if there's interest, but I'll give systemic, I will give radiation therapy and settle the brain lesions first and then move on to systemic therapy. So now you give the systemic therapy, and you have to make a couple of decisions based on the response. You have three categories of responses. Either you have good response, whether it's partial or complete, or you would have stable disease, and the third outcome could be progressive disease. Progressive disease, easy, you move on to the second line. It's unfortunate, but the decision about it is easy. Those who have respond to treatment, I give prophylactic radiation treatment to the brain in both limited stage and extensive stage. And I also recommend, the thoracic radiation therapy, consolidative radiation therapy. Some people may debate that. I really look at the patient's general condition and performance status and so on, and the type of response. And I would consider this strongly, basically. This is the shopping list of the NCCN type of list of chemotherapy, systemic therapy that you would give for cancers. I would focus on just the new treatment, which are the basically combination of immune therapy with chemotherapy. In the second line, I will focus on lorbenectedin, and then in the third line, I'll focus on the checkpoint inhibitors. So small cell lung cancer has been plagued with so many failure of treatment, unfortunately, over the last 20, 30 years. More than 40 phase 3 studies studying more than 60 agents took us nowhere, basically. And you see a list of previous trials, some of them at least. And the overall evolution of systemic therapy is basically was slow. And all my career, I have been dealing just with the platinum etoposide, the last couple of years, we have the checkpoint inhibitors introduced to that. I will mention some of these studies that was practice changing, got FDA approval. I'll just focus on this, and I don't want to confuse people with too many studies that has no impact on practice. So focusing on first line treatment, I will mention 2 studies and then one briefly. The first one is the Empower 133. Basically, Empower 33 took chemo-naive extensive small cell lung cancer patients and randomized them into atezo with carbo etoposide then maintenance with atezo, every 3 weeks, till progressive disease or loss of clinical benefits. The control arm was placebo with carbo etoposide, and then placebo, maintenance. The primary endpoints were progression-free survival and overall survival. The overall survival significantly improved with the atezo. You see here there is a gain of 2 months, with the combination arm, 0.7 hazard ratio with significant p-value. At 12 months, you always keep this in mind, you have more than 50% of patients in the combination versus 38. So you are gaining like 14 points at 12 months. This is the progression-free survival, also got prolonged with the hazard ratio of 0.77 and p-value of 0.17. Number-wise is not that big, but there is nevertheless there is a difference. And when you look at the, whenever you gain always in any study, whenever you have some gain in terms of improvement in outcome, you should look always at the price. What the patient is paying for that in terms of side effects. So actually, if you look at, the side effects, actually, if you look at the grade 3 and 4 here, almost, no major difference. And even when you look at the immune therapy related adverse event, they are all the severe one, 3 and 4. We usually pay attention to these toxicities. They are all less than 2%. So, and generally they are manageable treatment, manageable adverse events. So looking at global health status, it did improve also with the combination. So bottom line, I don't want to read the conclusion of this pivotal study, but basically, this showed improvement in progression-free survival, overall survival, improvement in global health status. So this became an approved treatment for the combination of atezo with carbo, BB16 became an acceptable standard treatment for first-line extensive small cell lung cancer. The second study is the Caspian study, which basically assists in extensive small cell lung cancer treatment naive patient, but who are suitable to receive platinum therapy. 4-drug regimen, durvalumab and tremelimumab, with carbo etoposide 4 cycle, or the durva with carbo etoposide 4 cycles, or the chemotherapy alone, carbo or cisplatin etoposide 6 cycles. So this study allowed carbo or cisplatin, unlike the other study is, the Empower that we talked about, it just was carbo etoposide. Here it was carbo or cisplatin, 4 cycles with the immune therapy, or 6 cycles if it was, just chemotherapy. And then the co-primary endpoint was progression-free survival and overall survival. So the baseline characteristics basically were matched between the 3 groups. I'll focus on the important results that, looking at the overall survival, durva plus EP, there is a gain of like 2.4 months with significant p-value, hazard ratio of 0.75. And you look at the 1-year cutoff landmark, 52.8, 39.8. So again, similar gains of survival. You see here the different subgroups. Many of the subgroups benefited from the combination with durvalumab. Sometimes you may have to individualize the treatment, think about it. Generally, smokers do benefit from checkpoint inhibitor across the board. Elderly people are, the older the patient, the less likely to benefit from it, and so on. The progression-free survival after the 6 months, actually, you look at all the landmark analysis, 12 months, 18 months, or or 24 months, there is significant improvement in progression-free survival. The response rate is much higher in the combination with the Durva, 68% versus 58%. And the duration of response, as you can imagine, like we see in all checkpoint inhibitor studies, once you get a response, usually it's durable, and that's what makes a difference. So although numerically here is not different in overall, but you can see the difference clearly in the tail of the curves. Now, I did not mention the 4-drug combination because it was associated with more toxicity. I will show you in the next slide. But the overall survival did not differ between the 3-drug combination versus 4-drug combination. So you see the curves are overlapping. But in the combination with immunotherapy anyway, better than chemotherapy alone. And as I told you, this is the side effect. If you look at the grade, all serious side effect here, 45% in the 4-drug combination, 45% versus 36. So basically the 4-drug combination was more toxic, did not impact the overall survival, even if there was some difference in progression-free survival and so on. But that's in the end of the day, like splitting here. It did not make a difference over the 3-drug combination. So this is show you the both studies with the numbers almost identical, close to each other, confirming the same principle actually of that adding checkpoint inhibitor, at least in these 2 drugs, did make a difference. So again, then durvalumab with etoposide platinum, whether it's carbo or cisplatin, showed to show a benefit to the patients, and also was added to the guideline and the FDA approval. So you look here at different studies, and all of them have the improvement in overall survival and in the progression-free survival, generally. I will just mention I will not talk about the study that has NIVO because most likely it will not be pursued, and NIVO will be just approved in the 3rd line. But I will talk about the key node 604 briefly, which is basically combining pembrolizumab or placebo with etoposide platinum in 1st-line non-small cell lung cancer. So this is the drug for the study arm, Pembro 200, and the etoposide with one of the platinum, and the maintenance Pembro. Matched group, and then you see here, the note here that the survival did not cross 12 months, like similar to the other studies. So it's 10.8 months versus 9.7 months. 1 month gain, hazard ratio a little bit less than the other, significant p-value. This is the data. Overall survival here, you see it. So this is overall survival intent to treat, and this is for as treated patients, similar. This is the summary of response. There is a little bit more improvement in response with the addition of Pembro, and a little bit improvement in the duration of response, especially in the tail of the curve. So this doesn't have yet FDA approval. It may get approved, it may not, but this is just something to keep an eye on it. So for now, for 1st line, and I'll summarize that in the end, we have the Durva with the platinum etoposide, or Atizo with carbo etoposide. Let's move on to treatment beyond the 1st line. Again, I'll mention only the studies that has impact on treatment on the practice. So there is a study, Checkmate 032, which is Nivo and Epi, was studied in multi-cohort phase 1 to either non-randomized sequential treatment or randomized cohort, using Nevo 3 milligram versus Nevo 1 milligram per kg with Epi 3 milligram per kg for 4 cycles, then maintenance. So, these are the overall population. It's used in second and third line and beyond, and it's used in sensitive and resistant disease, which is, usually this is defined by progression within 3 months or before or after 3 months as a cutoff. So when you look at the side effect, of course, when you have the combination, you have more side effects. So here you look at the grade 3, 10 versus 2%, and including the immune therapy related side effect. Well, for the non-randomized cohort, there was some benefit for the combination of Nevo Epi. You see here the differences. However, without wasting too much time, when you do the look at the randomized cohort, there is no difference between them. Basically, the curves are just rolling together. So now they look particularly on third line use of Nevo, third line or later, as a monotherapy, and they found that there is like almost 12% response rate, and those who get response rate actually they have very good median control of median time to disease progression after the response is attained, almost 18 months. So when you get response, you get a very good median duration of response, and you see like almost a plateauing in the curves here in small population. So by this, the FDA approved nivolumab as a third-line treatment for extensive small cell lung cancer based on the data of 032. Now, it was studied as a second line compared with the chemotherapy, Nevo, compared to topotecan or amrubicin. And basically, when you look at the progression-free survival, actually the Nevo did worse than the chemotherapy, 1.5 versus 3.8 months. Even for the overall survival, it was no significant difference, numerically less, although you see some separation here later on. But the bottom line, the overall study is negative because you are losing a lot of patients early on, and basically it did not pan out. So no indication for Nevo in the second line compared to chemotherapy. So for Nevo, it's only approved third line for now. Now, the other drug that's approved third line is the Pembro. And basically, there are multi-cohort study. I will mention two of them: 0.28, Keynote 028, which is basically giving for extensive small cell lung cancer or PD-L1 positive, giving Pembro 10 milligram per kg till disease progression, 2 years, or intolerable toxicity. The other one, the Keynote 158. This one is actually a selected group. Here, there is no requirement of PD-L1. They give pembrolizumab fixed dose, and again for 2 years or until disease progression or intolerable toxicity. And you see here there's 16% response rate. There is very good duration of response, more than 18 months. So you see the curves of the duration of response with overall survival of 7.7 months. So Pembro got, based on these two study of the pooled data of the outcome response and outcome duration of response, Pembro get approved as third line, so in extensive stage small cell lung cancer. So that's the bottom line. Basically, there's no role for IBI and NIVO for now, just two single agents that I have mentioned in the third line. The last drug I'll be talking about is lurbinectedin, which is a novel anti-cancer drug that is similar to trabectedin. It blocks the activated transcription and produces double-strand DNA breaks. It has been studied in lung cancer with seeing the different efficacy there. But the study that got the drug approved is this study of second-line treatment, phase 2 study, as monotherapy in relapsed extensive small cell lung cancer. You see that there are 35% response rate, and the disease control is 68%. And when you look at the platinum sensitive, is the numbers are much better, so than the platinum resistant across the board. And you see the median overall survival 9.3 months, and the landmark 12 months is 34.2. So basically, this is compared to topotecan. The overall response rate is 15 to 25 or 25%. So it's much better. This is not comparison. This is just with historical control. And the median overall survival, 6 to 8 months, and here is a bit longer. So, and you look at the side effects, actually, they are lab side effect, most of them, that is especially the bone marrow suppression, which is generally manageable. When you look at other grade 3 toxicity or 4, they are really, there is nothing outside the routine chemotherapy that we are very comfortable with and we can treat. So lurbinectedin got approved on June 15, 2020 as a second-line treatment for extensive small cell lung cancer. So the take-home message, and this is the summary of my talk, so we can move to the case discussions and question answers. First-line treatment, you give atezo plus platinum etoposide. The platinum here is carbo etoposide, or you give Durva with platinum, carbo or cisplatin, and etoposide. If you don't have access to immunotherapy, you still, you can treat with the platinum etoposide. For the second line, lurbinectedin is approved. You have topotecan. I have actually very good result with the CAV. I still pull the CAV and use it. And, you may get response up to 50% of the patients, actually, if the patient can handle it, good echo and so on. And by the way, you always have platinum etoposide to consider, especially if patient has disease progression after 6 months. And third line, you have the NIVO and Bimbro if they did not get checkpoint inhibitor earlier, and then others, clinical trials and so on. And by this, I'll stop here and thank you very much.
Thank you, Dr. Jazia. This was a very nice overview of small cell lung cancer. So we are moving now towards the last segment of our session, and this is case discussion followed by some questions. I would like to request all my panelists to unmute their mics and start their video so we can have the full panel view. And my intention behind this case discussion is to get opinion from all of our esteemed panelists and sort of get a flavor of how each one would treat lung cancer depending on their own unique healthcare setting. So I think this would be a good learning for our trainees and students in this regard. So and also, sorry, I would like to welcome our fifth panelist, Dr. Abbas Khokar. Dr. Abbas is a head of oncology at King Edward Medical College and Mayo Hospital, Lahore. So welcome, Dr. Abbas.
Thank you.
I'm going to now share my slides, so just bear with me for a second. Okay, so can you all see my
Yes.
slides?
Yes.
All right, very good. So here we go. So my first case is a 62-year-old gentleman with non-squamous non-small cell lung cancer, which is metastatic to the adrenals and bone, and has a high PD-L1 TPS score of 90% by C22-3 assay. So what I like to ask my panelists, my first question is, in your health setting, if you see a patient like this come into your office, what would be your standard molecular panning, molecular testing panel? And I would further, as a secondary question, ask, what if this was a locally advanced cancer patient? So let me start off with Dr. Abbas. Dr. Abbas, you work in a large public health setup. And if this patient stage 4 non-squamous non-small cell lung cancer comes in, how would you work it up? What are the molecular testing would you do, or would you be able to do any molecular testing based on your unique setting? What are your thoughts?
Thank you very much, Dr. Hassan Shahryar. I am working in a public sector hospital, and we have limited resources. Probably we do not have diagnostic and molecular testing facilities in our setup, but we do have facilities in our city or in our country, and many labs do these testings. We have the option of stainings and PCRs and fish testing for many molecular studies. And we also have the facility of NGS, that is through Foundation Medicine. We can send our samples to for the foundation molecular testing. Uh, that is how we approach our patients, and this is actually out of pocket expenses that has to be bear by the patient himself or herself. That is why we stratify our patients according to their affordability as well as the need for the testing. Thank you.
Right. So, just on average, what percent of patients are actually able to have this molecular testing, and what typically do you order if somebody was able to, afford the testing?
Yes, it depends upon how we would like to approach this patient. Even the PDL1, that is hard to be, that is hard to, for most of the patients, that is not easy to afford. That is why we usually take into account their financial constraints as well. So if a patient is the clinical characteristics, they favor towards EGFR mutation that may be possible, that is Asian, non-smoker, young patients, then we usually order the EGFR mutation analysis. And we do discuss that there are options of immunotherapy, and but the cost would be high, and the support available will be less. Then
Right.
if only EGFR mutation analysis could be done, and that is very helpful. There are certain companies which are providing at low cost, so we
Right.
usually prefer EGFR analysis for every patient.
Okay, very good. Thank you for your response. Dr. Kamran Rashid, you work in a more private setting, uh, in a community private setting. So what would you be doing for a typical patient like this who comes to your office?
What I will do is I will do just the EGFR testing. I offer ALK also sometimes.
Hmm.
I've rarely seen it. I've very few patients with positive ALK. And PDL1 testing, I offer them, but only if they can afford immunotherapy. And obviously, foundation medicine has is available in Pakistan now. So anybody who has cost is not an issue for them.
Hmm.
I definitely order NGS for them. But standard wise, EGFR and ALK. That's where I stop usually.
Right. Thank you. Yeah, I think you raised a very good point that you would only order a test if you have a drug available for that patient, both in terms of access to that drug and also the financial affordability. That's the reality for our healthcare setting working in a low middle income country. Dr. Jazia, do you do anything differently?
Yeah. Thank you. I realize that the difference in the setting. We do actually for next-gen sequencing, we used to do 12 genes on, that have targets, in lung cancer. And now we expanded our panel to 50. We do it in-house. We have foundation medicine on backup. So initially we used to do the 12 genes, and then if they're wild type, we send the full panel to capture rare mutation like NTRK and so on.
Right.
And by the way, the fact that we are in a high-income country, that doesn't mean the government pay for that. You should. For many years, actually, we have a good partnership with the pharma. The pharma paid for next-gen sequencing on all Saudi patients, not only the National Guard patient. So
Right.
we do it in the National Guard in-house, but there is some partnership with the pharma that any Saudi patients have, lung cancer, they send the specimen to us and paid by the pharma, not by the individual or the government. But that's very important. Why the pharma probably are doing that too? Because we give the medication. So if somebody had the mutation or has high BDL1 and we need to treat them, we give medication. So there is win-win situation there. And I could really see that somebody having a mutation, an oncologist having a mutation with his patient and not able to do anything about it. I can imagine the moral struggle that you'll be going through. So, but so one has to deal with his own setting. But that's what we do actually. It's very critical in a practical sense. It is very critical, at least, to do for this patient the most common. And in our population, is 30% have EGFR. And if you look at ALK, 5 to 6%, and so bottom line in terms of standard of care, I would not jump in a setting where you have access to treatment. I would not jump with this PDL1 90% right away to immune therapy without ruling out mutation.
Right. I think you raise a very good point that cost is not just an issue for low middle income countries. Even high income countries do have different other constraints when it comes to cost issues. Now, just wanted to clarify: do you order NGS upfront on every patient with stage 4 lung cancer, or you do order a panel of?
No, it's automatic. Actually, the doctors, the pathologist does it automatically.
Automatic. Okay, great. Dr. Tawfiq, so you are at Emory University Hospital. How is your practice with stage 4 adenocarcinomas?
Yeah, thanks for the question, and it's actually interesting to hear the different approaches from different settings, and it's very impressive how the decision of testing or not testing is driven primarily by whether or not the patient can actually get access to the drug, which I think is critical, because why test for it if you can't use it for treatment decision? But the Saudi approach is quite interesting, that the pharma will pay for the testing. The government doesn't pay for it, but the government pays for the drug. Is that correct?
Yes.
Okay.
Actually, I practiced in the US for 17 years, and it was like unheard of to tell pharma to pay. And actually, they have been doing that for the last 10 years. And by the way, this is even in Brazil. There is a consortium of pharma that paying for also for molecular testing. So this model is being done in different developing countries. And it should be considered actually in Pakistan and other countries. But the issue there is with access to treatment. That's the most relevant one.
Yeah. So in the US, it's just like everywhere else. It's not every patient that can afford the cost of treatment with targeted therapies. But I would say perhaps 70–80% of our patients would have some sort of insurance, depending on where you practice. And if they have insurance, that is typically covered for the testing as well as the treatment in most cases. Where you do not have insurance coverage, there is the patient assistance program, where a lot of patients can get subsidized access to the drug. So oftentimes we don't think about payment for the drug because we know that most likely the patient will get access to that drug one way or the other. So for our advanced patient, regardless of histology these days, we profile everyone. We use NGS. So there was a recent study, not recent again, it's about 3 years old now, by Dr. Nate Pennell at Cleveland Clinic, where they actually looked at all these different approaches. So sequential single gene testing of EGFR if that's negative, then go to ALK if that's negative, go to this or that, versus broad panel NGS testing. And they showed that the broad panel NGS test is actually much more cost effective in the long run. Because you avoid having to go repeat biopsy because you exhausted the tissue. You get all your results within a very short period of time. And then there is convergence in terms of cost. You know, the cost of doing 1 or 2 gene testing individually is not too far behind just doing a 700 gene panel NGS testing. So for us, we do NGS testing for practically all of our patients. We used to do it in-house, but the cost of updating the testing platform actually becomes enormous. So it's actually better to have the commercial labs do it. So we partner with commercial labs.
Okay, great. So what I'm hearing is that barring the financial aspects, you would order upfront broad-based NGS testing in all lung cancer patients with stage 4 disease, correct?
Yes, non-squamous.
Non-squamous, right. Okay, now would anybody order EGFR testing or molecular testing in the locally advanced setting, meaning not stage 4 disease, but something like stage 3B, 3C? Would that ever be an option, do you think, in any patient? Dr. Tawfiq or Dr. Jazia?
You know, in the earlier stage now, it's becoming clearer with the ADORA and other studies. In the locally advanced, that there will be no use of targeted therapy. I would not. But to tell you the truth, I mean, maybe it's biased because of majority of our patients in our institution, because we are a tertiary center. We are doing it on all patients almost, you know,
right.
All the stages. But in terms of indication, locally advanced, that patients get chemo, radio, no surgery, and you know, I would not do it unless. And we found that, you know, actually in large study, real world study of 3,000 patients, that for stage 3, we find a lot of people doing EGFR testing and treating with TKIs. And as you know, stage 3 is a heterogeneous group. So if you are not going to give concurrent chemotherapy and you are going to give systemic therapy, well, you might as well give the best systemic therapy for that particular patient. Right.
Yeah, I think that's a great point there. I think I'm going to move on a little bit ahead of in this case. So coming back to the case, this is a 62-year-old gentleman. He has a high PD-L1 score. What would be your first-line treatment in this case? Now, we have 7 options, and all these 7 options are actually FDA approved for somebody who fits this description. So what would each one choose, starting off with Dr. Jazia? I think we lost Dr. Tawfiq here. I hope he can get back in. But Dr. Jazia?
Yeah, I would. So the mindset, how you see PD-L1 more than 50, right away Bimbro come into the equation. So generally. I know there are other approved indication that you can give with atezo and combination and so on. You know, but I think I'm very comfortable whenever it's more than 50 to put Bimbro in the front line. And most likely in most of my patients, I'll use Bimbro as a single agent, and that's probably the common practice in the US too. If really the patient is marathon runner, good performance status, and so on, and you know, especially if, you know, I see that there's a big tumor burden, I may use the combination of carboplatin and Bimbro. But you know, the most common approach for me will be single agent Bimbro.
Okay, great. Thank you. Tawfiq, thanks for back in.
Yeah, sorry about that. I think my Zoom ran out and dropped. I don't know how it was.
Well, I hope it doesn't drop out again.
Yeah.
So, yeah, so these are the choices we were talking about. What would be your preferred treatment option? The Keynote 024 single agent Pembro, or the Keynote 189, the chemo IO. We have the Checkmate 227, the ECOG chemo Bev, and then the IMpower 150. How do you decide which combination or which one to use for these patients?
Yeah, so I think these are all, relatively speaking, appropriate options except for the chemotherapy by itself.
Right.
And now you're faced with luxury of options and then trying to determine which one is best for the patient. So this
Right.
is where you have to balance potential toxicity
Mhm.
to likelihood of benefit and the rate at which you need to achieve that benefit. So for a
Right.
patient here where it seems like oligometastatic disease, small volume disease, not terribly symptomatic, high
Mhm.
PD-L1 expression,
Mhm.
and from all we know, there doesn't seem to be any real contraindication to the use of immunotherapy. Single agent immunotherapy would be the go-to
Mhm.
approach here. No,
Mhm.
molecular
Okay.
testing you already said was done, and I'm assuming negative.
Right. Yeah. Yeah. We're taking that out of the picture at the
Right.
moment. Dr. Kamran, quickly, what would you do in your setting?
Yeah, if the patient can afford it, single agent Pembro, provided patient is asymptomatic, doesn't have high burden of disease. If high burden disease, I'll combine chemo with it. In my
Right.
setting, usually what I do is, since atezolizumab is approved, we don't have the other options available.
Mhm.
My go-to option in affording patient with adenocarcinoma is carbo-pemetrexed with atezolizumab. There is Empower study in which they have used PEM carbo with
Right.
atezo. So, or I can go to the Bev carbo pacli
Oh.
atezo option in these patients. We use a lot of atezolizumab because it's available in our part of the world.
Mm-hmm.
Other Pembro,
Mhm.
it's not available here.
Right.
Yeah.
Atezo is the only registered immunotherapy here. So yeah, we
In
tend to use
Pakistan.
that. Correct. Yes. So we tend to favor those options more.
I see.
Dr. Abbas, and would you do anything differently, or you agree with the panel? Dr. Abbas, can you hear me? Uh, okay, Dr. Abbas, can you hear me?
Yeah, I can hear you now.
Sorry, yeah. So I was just asking, would you do anything differently, or do you agree with the panel before we move on to
Yeah,
the next case?
yeah, I agree with the panel. We use atezolizumab in combination, depending upon the patient situation, patient condition,
Right.
tumor burden, whether
Okay.
to combine which chemotherapy. So I
Right.
agree with the panel. Yeah.
Great. Thank you. So let's go to the next case. So this is actually somebody I saw in my practice recently. This is a 86-year-old gentleman who presented with 3 months history of dyspnea. He had a chest X-ray done outside, which showed a right upper lobe opacity, and then was followed up with a CT chest, and that showed a 3.5 centimeter irregular right upper lobe mass and borderline enlarged mediastinal nodes. He had a CT guided biopsy done, which showed a moderately differentiated adenocarcinoma. TTF1 was positive, and had a baseline PET scan, which staged it as T2N3M0. Now, he has a relatively good preserved performance status, I would say ECOG 1. However, he does not wish to undergo chemoradiotherapy as it would impair his quality of life. So, how would my panel treat or work up this patient further? Starting with Dr. Kamran.
Okay, so it's a 3B disease, right? It's N3,
Right.
so it becomes
Yeah.
3B,
It's
and the
unresectable. Yes.
chemo
Yeah.
RT, chemo RT is the standard of care, followed by
Right.
Durva based on
Hmm.
specific trial if patient can afford it. What
Right.
I would do is if the patient does not want radiation, uh,
Hmm.
one option will be doing some EGFR testing on this patient, and
Hmm.
I would like to get the PDL1 testing. Though in
Hmm.
the Pacific trial, the PDL1 did not make much of a difference. Both the PDL1 positive as well as negative got it durvalumab. So I would
Right.
like to get the EGFR testing if the patient is
Hmm.
EGFR mutated. One
Right.
option will be offering him
Okay.
osimertinib on
So,
19 or exon 21
right.
mutation.
So we'll get to
I would like
that
to
next.
offer him
So you will
osimertinib.
like to order molecular testing
And
and
other option would be
PD-L1.
just offer.
Right.
Yes.
Okay, great.
Yes.
Dr. Jasia, this patient does not want chemotherapy or radiotherapy. He's stage 3B. What would you suggest?
He does not want both of them, or he does not want the combination?
Does not want both of them. Certainly does not want chemotherapy alone either because of toxicity, quality of life issues.
Yeah.
What do you do in
Well,
these
this
situations?
is a practically stage 4, practically.
Right.
Now it's a stage 3, but
Right.
when there's a tumor there, it's
Right.
so.
Right.
Then you think of non-chemo, which is immune therapy and targeted therapy. So I would do PD-L1, and I will do the EGFR. I'll do the next-gen sequencing actually for us. But and then if there's targeted therapy, I will use targeted therapy.
Great. Tawfiq, do you agree, or would you do anything differently?
Why does he not want the chemo or radiation is the first thing. Because at times it's just that people have heard stories, and
Right.
at least if you can talk to them about why, if that is completely off the table, then I agree with the, looking for alternative options. Now, remember, pembrolizumab, at least in the US, the approval for pembrolizumab will actually cover this patient.
Right, okay.
Because when the Keynote 042 was designed, they allow patients who are otherwise with locally advanced disease, but for whatever reason cannot go for definitive therapy, to go on that trial. So based on their eligibility, the approval for single agent pembrolizumab will actually cover a patient like this. So if the PD-L1 is positive, that will still be an appropriate option for this patient. Just 1% is adequate. But for an 86-year-old, I think more likely that you're going to find a driver alteration that will make it easier for them to just go on the targeted therapy if they never smoked.
Okay, great. Yeah, so we could not do a PD-L1 because there was not much tissue left in the biopsy specimen. However, he was able to get EGFR and ELK testing done. The ELK testing was negative, but his EGFR showed a dual complex EGFR exon 18 G719X and EGFR exon 20 S768I mutation. My understanding is that both of these mutations in the EGFR are relatively TKI sensitive, although the data can vary from study to study. There's no great prospective data. So this is what we found. And so how would you treat him next? Starting with Dr. Tawfiq again with you.
Yeah, so given what you have here, a second generation EGFR TKI will be reasonable with afatinib. So afatinib has, at least based on current data, the best response profile when it comes to some of these atypical EGFR alterations. The G719X is surely sensitive. The EGFR exon 20, depending on the specific location, whether it's near loop mutant or distant loop mutant, may either be sensitive to the classic EGFR TKI or to the EGFR exon 20 specific alteration. So the 768I, which is more of a distant loop mutant, is more likely to be sensitive to the exon 20 specific inhibitor. Which at this point, given where this patient is only available as part of a clinical trial, so you won't be able to use it as standard of care. But given the compound mutation, then going with the second generation EGFR TKI will be reasonable.
What are your thoughts about the third generation TKI inhibitor?
So
like osimertinib?
If you want to use osimertinib, what we know about osimertinib for these alterations, you have to double the dose. So the 80 milligram dose is probably not as effective, especially for the exon 20. You have to go to the 160 milligrams, which is also safe. In the phase 1 trial, the 160 is just as well tolerated as 80. But because the efficacy was comparable, the recommended phase 2 dose was 80 milligrams. So that's why we use it. One other strategy that could be considered, we just finished a trial in the US sponsored by the NCI, is antibody plus osimertinib. So combining necitumumab, for instance, or cetuximab with osimertinib could be particularly effective in the exon 20 patients.
Great, excellent. Dr. Jazia, if you run into EGFR exon 18 and exon 20 mutation of these types, what do you typically offer?
I will use osimertinib first. We used to use afatinib in the past, but now we are not using afatinib, so it's not readily available. So we'll use osimertinib. And by the way, for accessibility, any TKI in these patients is better than nothing, or better than chemo, by the way, irrespective. So there is better efficacy of certain TKIs than others, but if you have access only to gefitinib, I would give gefitinib,
Right. Okay, great. Yeah, so we gave him osimertinib, although we gave it a standard dose of 80 milligrams, and he tolerated that very well. He's still on it, but haven't seen any response. So it's only stable disease at 3 months. But I think your point is very noted that maybe a higher dose could be used, Dr. Tawfiq, to maybe get a bigger response. Now, you also mentioned very aptly that exon 20 is a heterogeneous group, as there are some mutations which are sensitive to TKI and others are insensitive to TKIs, and particularly exon 20 insertions. So, is that so? How would you treat exon 20 insertion? You mentioned clinical trial, but is there any TKI currently available that you would use particularly, or would you go to chemotherapy, say if this was a very fit patient? How do you deal with it, Dr. Tawfiq?
Yeah, the exon 20 are very TKI insensitive. But if you look at the conformational change induced by the insertion, so you have two classes. You have what we call the near loop insertion mutant and the far loop or distant loop mutant. So the near loop mutant affects the receptor tyrosine kinase activity because they're very close to that binding site. And that is the subtype that is more likely to respond to the classic EGFR TKI. The best data we have so far was with afatinib. Osimertinib also appears to be effective, but we don't have as much data with osimertinib because it's relatively newer. If it's the distant loop mutant, so those ones don't tend to affect the kinase activity of the receptor. So using the classic TKIs is less likely going to work. So that is where you want to look for the exon 20 specific TKIs.
Okay, great. Thank you very much, Dr. Tawfiq. So I'm just being told that our time is up. We have to conclude this session. I really like to thank all of my panelists once again for joining in live and taking time out from your busy routines. And I also hope that our audience found it informative. I'm sorry we didn't have time to take questions, but we can try to get back to our questioners later via email. So thank you again, and have a good rest of the day or night, wherever you happen to be in the world.